anything. I mean, he is doing more of cataracts and seeing these cases. Since he has the ability to do a vitrectomy, so he has no hesitation in doing a vitrectomy in these cases. Now, this is a very basic course. We are not going to describe a whole lot of theoretical things. Our stress will be on practical things. As to when you see a patient, what do you decide, how do you decide? We are not going to quote much of literature. It will be an experience, individual based experience, plus whatever is the real policy or how do people try to manage a case. Now, endophthalmitis is something which I think happens in anybody's hand. Though the prevalence and the incidence of this condition has gone down, but it is a very dreadful thing to happen. It gives you sleepless nights. The idea is to catch these patients as early as possible. And now I request Dr. Arvind Dubey to give a similarity to what we have learned during our general surgery postings. Dr. Arvind Dubey.
Thank you so much. Actually, when we say post-operative endophthalmitis, that is an infection in the eye, we generate in our mind a very special approach or a very special impression. Our first exposure to any surgery or surgical infection for that matter is when we do our general surgery postings in third year MBBS. And as you will all remember, when the consultant is taking round and the nurse says that this patient has developed fever or temperature, first thing that he suspects is infection and the antibiotics are augmented or new antibiotics are added. I compare development of fever following a general surgery with increased anterior chamber reaction following an ocular surgery. The second sign to appear is an induration of the wound or pus over the wound, and this I compare with appearance of hypopyon in the anterior chamber. The third thing, that the infection goes deep down and involves the entire peritoneal contents, what you call as peritonitis. This I compare with involvement of vitreous. And the last thing is generalized spread and septicemia, and that I compare with panophthalmitis. The emphasis in this course is that you should be able to catch your cases here. If you are able to catch your cases here, then you get the best results if at stage 1 and stage 2 you are treating the cases. And if you treat cases when there is almost complete involvement of the vitreous, barring very early cases, or when there is panophthalmitis, whatever treatment you apply is actually an academic exercise. Now, EVS study is often quoted in all instruction courses or literature related to post-operative endophthalmitis. But I wish to draw the attention of the delegates to the fact that this study is actually meant for vitreous surgeons, not for the anterior segment surgeons, because this study simply reported the outcome of vitrectomy in group of patients having vision better than light perception or having vision lesser than light perception. The emphasis in this course is that you should be able to avoid vitrectomy in cases of post-operative cataract surgery infections. Second study which is prominently quoted is ECSCR study, wherein they studied the role of intracameral antibiotic at the end of surgery, but they still reported that though it reduced the incidence, but that means that the infections still occurred. So even this study is not relevant for our purpose. Dr. Tiwari, please.
Now, we are now addressing this instruction course to the basic anterior segment surgeon. Basic anterior segment surgeon who has a good operating microscope, who has a phaco machine, who has an A-scan biometry, of course, slit lamp and ophthalmoscope. The idea is these are the basic instrumentation who an average ophthalmologist operating today as an individual or solo practitioner has that. Now we want to show you how do you want to make use of the instrumentation you have got. We are not talking of rocket science or things like that. I am not talking of CAT scan and this and that and all that. The basic point is you have got these basic instruments. You have got this. You have been using this basic equipment every day. The basic point is how to make use of it.
Because the underlying sentiment in our instruction course is that infection is not a surgical pathology. And therefore, if you are able to diagnose infection within the means that are available with you, you should not be reaching the stage of vitrectomy in vast majority of cases.
Now, how do you detect? Like, first time you have operated a patient and you are seeing the patient. Now, naturally we have to know what are the initial symptoms of a particular case. Now, as it is said, blurred vision, a red painful eye, chemosis of lid and edema. Now we would like to know from the panelists at this stage, like how much do you agree with these and what point do you think is important when you are diagnosing an early endophthalmitis? Dr. Nayak, please. Dr. Nayak.
Actually, these are definitely the classical symptoms of endophthalmitis which has been described, but that is probably it's little late. The basic purpose of this course that we want everyone to diagnose it early,
right.
And especially with the modern type of surgery where the incisions, given corneal incision, is almost like a traumatic. Most of the surgery is trauma is very minimal. In that case, if we wait for the lid edema or the conjunctival congestion or chemosis or the pain, those things may not be there. So we have to diagnose it at the earlier than this stage, when the patient reaches this stage. So where probably these things are important, but visual acuity is also equally
very good.
important.
I think he has made a point. If you are having a patient on the first day and he says my vision is not as good as I expected, or you find that there is no other pathology in the fundus and his vision is not improving, then something should go in your mind. That look, something is going wrong in this particular case. That would be the earliest sign. Whether lid swelling and all is there, but vision would be the sign for detecting these cases. Now, what is your opinion about this, Dr. Lalit? About those symptoms?
Whether patients these days present with lid edema, chemosis, painful and red eye.
Gone are the days. The reason being of microincision phacosurgery. The incision is so small, there's hardly any reaction. Your surgeon should be familiar with what trauma he has caused during surgery and what to expect. This will happen provided you see regularly all your patients slit lamp. If you are following the patient slit lamp, then your tentacles will go up. That this patient is having more reaction. So we generally depend more on signs rather than symptoms. So signs are of paramount importance.
Like what he's trying to say is very important. You are operating these patients day in and day out. You know what is going to be the reaction in this particular eye. If you have had an uneventful surgery, what is your usual kind of a reaction in an eye? If you think that this patient should not have this kind of a reaction, which is beyond your imagination, then again you suspect this. Right.
I think one important thing that should be mentioned regarding symptoms is, see, when on the first post-op day, especially in a situation where you are operating cases who have very good vision, the patient could say there is some blurring of vision. So that's not so important. But what about a patient who came to you on the fourth day saying that now my vision has become a little blurred from what it was before? This should raise your tentacles that you have an early endophthalmitis coming. You shouldn't take chances with it.
So carry home of this discussion is that do not look for chemosis, lid edema, painful and red eye. If there is unusual reaction, unusually low vision, or a patient returning with a dropped vision after first 2 or 3 uneventful days, your tentacles should be raised that it is infection. Now the usual story with us as vitreous surgeons are that the phaco colleague telephones saying, sir, everything was all right, and on third day this patient has suddenly come up with a hypopyon. Now actually it's not a sudden hypopyon. Hypopyon today, for today's microscopic ophthalmology, wherein both non-surgical, that is outpatient work, and surgical work in the theatre are done through a microscope, hypopyon is a late presenting sign. I'll invite comments from Dr. Dinesh whether he considers hypopyon as a late sign of infection or he thinks that it is the first presenting sign.
See, the point is, hypopyon as a sign is not a doubt. So that's not the issue. The issue here is that what if a patient presents the way the second slide is? Now, if a patient comes to you, even if superficially with a torchlight, this is what it looks. The question is, supposing he's come to you with the complaint that my vision is dropped, and you do the visual acuity testing, and you find that it has dropped by a line or 2 even. That itself is the first sign something's going wrong. Now you do a slit lamp examination of this patient and you find that there are cells in the anterior chamber, and you could have cells in the anterior chamber without a hypopyon. This is an early endophthalmitis developing in this patient. This is especially if on day 1 he had virtually no reaction, and now on day 4, 7 or beyond that, suddenly you find that such cells have increased. Please be very careful not to ignore these findings.
The message is that hypopyon appears visible when there are more than 50 cells per high power field. And infection should be suspected when there are 5 or more cells per high power field. And that is what Dr. Dinesh emphasized, and also Lalit, that a careful slit lamp examination. So at the sake of actually behaving as an undergraduate teacher, I'll take you through the standard drill of a slit lamp examination. Now this is optical section of the cornea, and this is the illumination falling on the iris, wherein you are able to see the clear iris pattern and the intervening space is empty, that is optically clear. This is the normal situation in an unoperated eye. Once you have done surgery as per your handling or your level of skill, on first post-operative day, some pigmented particles or some cortical debris may be seen suspended in the anterior chamber, and yet the space is clear. This is an eventless surgery and this is not to be paid any attention to. But if you are able to trace the beam of light across the anterior chamber, this is presence of flare grade 1, and this implies that there is a greater post-operative reaction than should occur these days. If this becomes denser, that part of the iris pattern is hidden and more particles appear to be suspended, this indicates grade 2 haze and a greater inflammatory reaction. And subsequent to this, the entire iris pattern may be hidden and there may be just a very hazy view of this beam of light traversing across the anterior chamber. This is grade 4 flare, and even now you can be reasonably sure that there is no infection. But if in this beam of light you are able to see some structures, morphology of which can be defined through slit lamp, this means cells are present in the anterior chamber, and this should be considered as an ominous sign indicating likelihood of infection. And this slit lamp drill should be done in all cases in a standard dark room with brightest illumination available with the slit lamp, 16x magnification, and making the beam as narrow as possible in all cases wherein you have got more reaction than is anticipated. The message is that presence of cells in the aqueous humor is a sinister sign indicating infection. May I invite comments from Dr. Nayak?
One thing important is he has mentioned it very casually. The examination should be done in a dark room. Let's be very clear about it. Normally what happens is we are sitting in the OPD, some lights are on in the room and we make the patient sit and we fatapat karke chalo. This is very clear, because if we are going to suspect this, if we want to detect it early, it has to be dark examination.
At the end.
Not now. Any questions will be in the end. You can write down, send it to the panelists, they will answer the question.
Write down your questions and send. May I have comments from Dr. Nayak that once you see cells in the anterior chamber, what is your next step?
The moment you see that there are, as Dr. Arvind Dubey said, that if you see that slit lamp examination flare and cells, if you are noticing cells, then you cannot leave it as it is. Then you have to examine also, apart from the anterior vitreous. For that, the best way probably to examine is to dilate the pupil and then see